Hello, I'm delighted to be here today to share the work of our group at the Lauros Hospice in Leicester concerning the experiences of bereaved family caregivers of having what we call just-in-case medicines. So these are injectable medicines for managing symptoms that may arise in the last days of life and are put in the patient's house in advance of the patient actually needing them. These symptoms are common and fairly predictable, whatever the patient is dying from, and this anticipatory approach is endorsed by NICE, advocating something for pain, usually morphine, something for nausea, something for agitation, and something for respiratory tract secretions. Having these medicines available is thought to achieve a lot of benefits, but actual experiences and outcomes have not been researched. In this study, we've looked retrospectively at the experiences of family caregivers, the people who were looking after the person who was dying. So our study was in two phases. First of all, we sent a questionnaire to 100 family carers who all had contact with the hospice services, and we knew from screening that they'd all received a prescription for these anticipatory medicines. And then we selected a sample of those that returned the questionnaire to explore in more depth their experiences. The questionnaire and the interviews explored a number of areas about the practical and process elements of this anticipatory prescribing and the actual use of the medications. We explored the carers' understanding and experiences and their thoughts about how the whole system and their experiences might be improved. We also gently explored what the appetite would be for family carers themselves to give medications. So we had a response rate of 38% to the questionnaire, and of them, 92% remembered having the medications in the home, and 87% felt there were benefits to having the medicines, helping them feel reassured and relieved that medicines would be available at the time of need. However, some found having the medicines difficult or upsetting. And in this presentation, I'm going to focus on the 14 interviews that we've analysed, which were purposefully sampled against the criteria shown here to ascertain the broadest diversity of experiences. So the first theme that emerged was about what these medicines communicated to the carer, and three elements are illustrated here. I was sort of staring into the abyss, and I thought, what's going to happen? How am I going to be able to manage this? I had not realised the full implications of the medications. But the impact of having the medicines suddenly made the person realise, see face to face, that the person they were looking after was definitely going to die. There was some misinterpretation of what the term end-of-life medicines meant, and some nurses and doctors call these end-of-life medicines, others call them just-in-case medicines, and no doubt there are other phrases. But the interpretation here in this quote is that the medicines will actually be used to end someone's life. So I know there was more than one drug there, and there must have been. I'm assuming there is an end-of-life injection. The communication also made the people think that there was high risks here, that these were medicines that were worrying. But she, the Macmillan nurse, said, don't worry about them. We'll sort them out when the time comes. You don't touch these because they're a deadly cocktail, aren't they? So our second theme that we found related to the practical elements of obtaining and storing the medicines, which were nice to have but difficult to get. So I had to go to three different pharmacies while he was at home, and all the time really poorly. And he was almost frightened of being on his own because he said, I don't want to die when you're not here. And sadly, these experiences of the burden to the carer and the riskiness of this situation were not at all infrequent and even more profound sometimes. So one said, I thought I would nip down to the doctor's, it's only down the road. So anyway, I came back 20 minutes later. I come in and went upstairs and she had gone. And others commented on the responsibility of storing, of having these medications in the house. And you were told that the police were involved if anything did go wrong. Enormously high stakes information and interpretation of that information given to people. And here one, which puzzled me but happened, and one pharmacist wouldn't let me have the medication because I didn't have proof of a locked cabinet. So this high stakes responsibility is by no means a unique experience communicated by the carers. Having the drugs in the house was no guarantee of smooth care, and quite a few people told us about delays and not having the best person for the situation, although some had good care to share. So here the nurse said, I think you ought to ring, and the doctor came within a quarter of an hour. Obviously excellent care. However, half a dozen calls and they sent the paramedic out. We didn't want the paramedic. She had a care plan to stay at home. And another, I rang for them and the nurse came out, a really, really lovely girl, lovely attitude. They all did, to be fair. I think I had to ring twice, and when she got to me, she said that she apologised for the delay, but the call had been put through to a different team, and she just happened to spot S's name in the queue. And there were other experiences at the point of need that people told us about where professionals were not trained or competent to manage the situation when they were sent out. So the nurse came along and said straight out to me, I don't know how to deal with these. A surprising number, surprising to me, talked about professionals that had been very tearful with them because the patient was dying and how that added to their burden. So she, here, an ambulance crew member, was doing things to her, checking her blood pressure. All of a sudden, she started crying. I said, do you want a cup of tea or anything? Are you all right? An enormous burden to someone who's already coping with their loved one dying. And despite the medications being available, there were barriers to actually using them. I called the emergency people out and she said, have you got the medicines here? And I hadn't got the paperwork. Well, I had got the paperwork and she said it's not been signed off. So I said, does that mean you can't give it? And she said, no, I can't. Several carers told us that they would have been willing to administer the medication themselves with training and supervision. Here one saying, considering the number of things they trained me up to do, that was something I could have done without a doubt. And often people commented on already giving injections for such things as insulin, and many also having some sort of healthcare background would certainly have taken this on. So, in conclusion, our questionnaire responses suggest that most family caregivers found having anticipatory medicines generally beneficial. In our interviews, carers described plentiful distressing experiences, especially where there'd been poor or inadequate communication, and professional support had been difficult to access at the point at which it was needed. And a good experience relied heavily on the competence of staff and accessibility of services. And some family caregivers would consider administration under advice and supervision. And I'd like to acknowledge the research team here, especially Alison Hillsworth, who carried out the interviews and analysed them along with Anne Patterson. And thank you very much for listening.